presenters are really going to help us a lot with this. They're going to go, hopefully, right, quite a bit over the osteology at the beginning of the presentation. We'll be looking at the pelvic girdle. And, what we call the coxal bone, left and right, is really three separate bones that fuse, starting kind of at puberty and going on into your early 20s. And these help form muscle attachment sites and support the weight of the body, and really important anatomy here with respect to pregnancy. In males and females, this pelvic girdle is protecting really important organs inside the pelvic cavity, like the rectum and the bladder, and of course, if you're a female, the ovaries and fallopian tubes, and all kinds of interesting things. So, like I was saying, early in development, these three bones fuse to form what we call the coxal bone. But we still, even though they're fused in the adult, we refer to the three sections of the coxal bone by their original terms. So we got an ilium. Do you all palpate your iliac crest right now? Okay, so that's the ilium. And then we've got a pubis, and what you're sitting on is actually your ischium or your ischium, if I can pronounce both ways. And on my Instagram feed now, I've got this dude who's just kind of making little comedy videos about just how absurd the English language is. Like no pronunciation rules. Like, so anyone just trying to learn English, no idea how to do it, unless you're lucky to be a 3-year-old learning it. So ischium, I don't know, heard it both ways. Pick whichever one makes you happy. And so you're sitting on the ischium, in particular the ischial tuberosity. Okay, and then on the lateral aspect, there's this massive indentation, which is called the acetabulum, that takes the head of the femur. That's actually the fusion place where these bones fuse. Right. And so this is an example. And usually I say, I'm not going to go over it, then I spend like 20 minutes going over it. Bam! So I'm not going to go over it. You're going to do it. But we're going to learn all these parts, Here I go. Like sartorius is coming off ASIS, and we're going to model some ligaments coming off the ischial spine and the ischial tuberosity, right? And with that, then we're going to make some notches once we add those ligaments. So we're gonna become experts on all these parts, okay? If you wanted to do a spinal tap, you can actually palpate the iliac crest, and if you take it back, that takes you to L4. That's how a doc will find a place to do a spinal tap. So anyways, really important anatomy, not gonna go over it. Same thing here, okay? A lot of important anatomy, we're just gonna have to soak it up on our own, okay? This is kind of from basic anatomy, so just expect you guys to be able to handle it. One comment, kind of the key thing today, we're going to think about how stuff gets in and out of the pelvis, and it has to do it through holes, right? So there is a hole that exists on the coxal bone without adding any ligaments, and it's the obturator foramen. But there's a couple other holes that don't exist until you add ligaments to the pelvic girdle. And we're going to find those on Cadavers Wednesday. We're going to model them with tape in discussion lab. Probably our presenters are going to do that too. So if you look at the ischial spine, if we were to run a ligament from the spine to the sacrum, that's going to help form a greater sciatic foramen. And if you look here at the ischial tuberosity, which is what you're sitting on, if you ran that to the sacrum, we'd make another hole. So we're going to make some sciatic foramina by adding some ligaments there. More on that later. Okay, I got to move on. Didn't want to spend a lot of time on that slide. So, we in a previous lecture thought about the sacroiliac joint, and anatomist debate. Is it synovial? Is it fibrocartilaginous? Is it both? I don't know. There's debates, but whatever it is, it's a joint that doesn't allow a lot of motion. Although in females, especially during pregnancy, because of the influence of hormones, a lot of the joints, probably throughout the body, loosen up. Ligaments too, and and that, serves the function of allowing the baby to move through the birth canal with less obstruction. So that's pretty cool. And the sacroiliac joint is no different. Pubic symphysis joins together the two coxal bones at the front. This is a fibrocartilaginous joint, just like the fibrocartilaginous joints that the intervertebral discs make, okay? Sacrococcygeal joint is not of high importance. So here's our pubic symphysis. Fibrocartilaginous joints allow a little bit of motion. If you're wondering, well, how can we get such a great range of motion associated with the vertebral column? Because we have so many segments that add up, sum up. But each individual segment is just generating a bit of motion. And so this is allowing the two coxal bones to articulate, in particular the two pubic bone parts of the coxal bones. And we can strengthen it by layering over the top and the bottom some pubic ligaments. Don't have this to see in lab. So like this is a case, where, for the first presenters, whatever, but like for everyone else, the first presenters, they were courageous to volunteer to go first. They're going to be great, but they're not. Maybe they're not going to hit it out of the ballpark. They might, but for everyone who's following them, I expect you to just do better and better and better. So like one thing you can do is if there's something in my lecture I mentioned and then you don't see it in the cadaver, maybe see if you can find a picture of it on the internet and put it into your PowerPoint or something like that. These are examples. These pubic ligaments, you're not going to see in the cadavers, but they help strengthen that joint. Yeah, so a little tie into something in the future in this lecture, and we'll come back to it in future lectures. This pubic tubercle right here, so kind of like superior, just inside of that fibrocartilaginous pubic symphysis. Do you see it? Right there. If I ran a ligament from that, and maybe presenters, you want to do this too, I don't know. You can see it in the cadaver, see it. If you run a ligament from the pubic tubercle to ASIS, that sartorius attaches to, we're going to call that the inguinal ligament. And that's a really, now there's like a little hole under that ligament, and that's another way stuff can get in and out of the pelvis. So for example, femoral nerve, femoral artery, femoral vein, a really important clinical anatomical region of the body, okay? All right. You guys can review the sacrum, right? Cool? All right. Okay, let's ask you again. If you looked inside the sacral canal, would we see the spinal cord there? No. What would we see? Any nervous tissue?
Yes.
What's it called?
Caudine point.
Cool. So, a lot of bony parts to the sacrum. Good. You can get that on your own. Okay? Is that enough time to process all that? Okay, moving on. Okay. So, right, Ernst 1.5 microseconds to process one slide. I think you should be fired. He's such a jerk. Sorry, guys. Okay, this is important. I'm going to spend more time here. You can see it on a radiograph. This is called a pelvic inlet. It's also a pelvic outlet. Everything above the inlet is called the greater pelvis or the false pelvis. So like, if you palpate your iliac crest and you think about, the iliac fossa. See the iliac fossa right here? All that iliac fossa, most of it anyways, is above the pelvic inlet, so it's in the greater pelvis, okay? But if we get down here below this red line, we're in the true pelvis. the lesser pelvis, less, I guess, cross-sectional area. That's where all the important goodies are. Reproductive parts, bladder, lower part of the GI tract, stuff like that, okay? How could we draw that line on a pelvic girdle? What you want to do is find what's called the sacral promontory. Here it is. This is on another slide spelled out. I'm just going to use the abbreviations. SP, sacral promontory. It's basically right below the fifth lumbar vertebra, right at the top of the sacrum, okay? And I'm just going to go horizontally along the pelvic girdle from the sacral promontory to the top of the pubic symphysis, and I'll do it on both sides. And I just made that red, whatever, circumference, and that's the pelvic inlet, so if you wanted to do that, okay? So we're going to start at the sacral promontory. We're going to travel along pelvic girdle. Now we're on the coxal bone, and we're going to go to the top of the pubic symphysis. And in doing that, we just like outlined whatever the circumference or the margin of the pelvic inlet. This is now here's a cross section, and you can see. So like right here would be where I just drew that red line, right? Okay. So right below it, now we're in the true pelvis, the lesser pelvis. Lesser because it's got less cross-sectional area, but not lesser in importance, right? This is the part of the body protecting female reproductive apparatus, uterus, fallopian tube, where a baby's developing, so incredibly important. Above it, greater pelvis, not as important, I don't know, functionally or clinically. So here it is again. Can we move on? This is getting boring. Okay, so what about the pelvic outlet? At the bottom of the pelvic girdle, there is no bone. That's a problem because actually organs in the pelvis, like the bladder and the vagina and the uterus, could prolapse, move to a location where they don't belong. They shouldn't be moving. If there is no covering to the pelvic outlet, so how do we cover it? We're going to add a muscular girdle there, and that's something we're going to learn about in the last lecture and lab of this course. And Justin was already wanting to prepare for his presentation 3 months from now. Yes, I like that. Okay. So that's what we're going to do. We're going to learn about the pelvic diaphragm, the levator ani. Although actually, this week's presenters, you're going to show us the levator ani too, aren't you? Maybe? Yes? Good. So, this is kind of cool and kind of neat. The male and female pelvic girdles are differently constructed in order to allow childbirth to be a little bit less obstructed. So for example, the pubic arch, this little region right here, right below the pubic symphysis, in the male is like less than 70 degrees, and the female greater than 80. We often use a little finger mnemonic to represent that. Use a little Winston Churchill World War II peace sign to represent the typical male pubic arch, whatever diameter, and the female do this sign, okay? So it's much wider. But there's other differences. Female pelvis is lighter, and it's wider, and you know what I mean? Now, we're going to come back to the pelvic girdle later in this lecture. I'm going to talk about some adaptations to it related to bipedalism. We shifted from quadruped to bipedalism. The pelvic girdle orientation has shifted compared to other primates to allow muscles to function in different ways for walking on two limbs. Okay, that's kind of cool too. So, like in particular, the orientation of the iliums is different from like chimpanzees and gorillas and humans. So I'm not going to test you on every detail in this chart. Okay, just want you to know there are major differences. I do want you to know that the pubic arch difference and that there are multiple differences to the pelvic girdles. Okay. Some slight differences to the acetabulum, with some potential clinical significance. The acetabulum, just to remind you, is this little divot's a bad word, divot's like a small little hole, isn't it? So this large hole in the coxal bone that receives the head of the femur. So in males, larger, females smaller. There's potential implications for hip dislocation, right? Okay. This, I'm not gonna test you on the numbers here, okay? So I wouldn't ask you a question like, what's the typical interspinous distance and the typical transverse diameter? No, go into OBGYN, okay? Which means you gotta go into medical school and you're in PT school, so that's okay. But I do want you to kind of just have an idea, a general idea that we can take these measurements. There's different places where we can take these measurements. And the reason we would do that is to get a sense for the environment that a baby's head is going to have to make its way through during childbirth. There's kind of more than two, but like two aspects of human anatomy that are good for one thing, but have really dangerous implications in another sense. So one of them is that our larynx drops down, and so that's presumably to allow us to do complex vocalizations. The downside to it is we're the only mammal that typically chokes to death. Okay? Bad. Okay, now here, got a great pelvic girdle for walking on two limbs, and so we can free up our upper limbs to throw spears and play badminton and whatever. Okay. Also, jumping the gun, I think it's such a cool story. Because we cook food, mostly, we've outsourced a lot of digestion to the fire. That means our GI tract can be shorter compared to cows and actually a lot of other mammals, okay? Because the fire is breaking down the food for us. So when it gets to our stomach, it's already mostly broken down, okay? And so there's a theory that states that because our GI tract doesn't have to be as long because we've outsourced a lot of digestion to cooking, we can instead funnel that energy to build big brains. So if you got a big brain, you need a big head. Back to the pelvis. If you have a big head and you're a baby and you're trying to get out of this birth canal, it is tricky. And so women would often die in childbirth in the past. Babies do. That's not the case in most other mammals. So two areas, right? It's great that we have big brains, but it's a major problem that we have giving birth. And so there are these constraints that we kind of want to think about a little bit, like that pose problems for a baby, especially if it has a big head trying to make its way through the birth canal. We can take these measurements. So that's what you're looking at here. And this measurement right here, the true conjugate, is really the major hurdle to a baby's head making its way through the birth canal. That distance right there. But we can't measure that with our hand during an exam. So we can approximate it with this green line here. Okay, diagonal conjugate. That's what this examiner's fingers are doing. So you can come up with an approximate value for that measurement, and it can give you insight on whether there's going to be an issue later, when the child's trying to make its way through the birth canal. Don't want to belabor this point. I think I've already been talking about this now for 15 minutes. Bad! Okay, moving on. So, spondylolysis, spondylolisthesis. Maybe, I felt like there was some confusion. You guys remember typical vertebra? Here's the arch. Okay, and so that's three processes, but then there's two superior articular facets and two inferior. So if you add it up, there's 7 processes. Okay, now let's look at it from the side. Something like that. And then here's a transverse process. And then, so here's a superior articular facet, here's an inferior articular facet. I'm kind of exaggerating. But so this region of bone between the superior and inferior articular facets is the pars interarticularis. That's just a common fracture site on vertebrae. So if you fracture one, spondylitis, but if you fracture both, then now it's really unstable. Like destabilize like the arch from the body. And so now the body can shift, it often shifts forward. This often happens in the lower lumbar regions. You see here, you see a lumbar body anteriorly displacing, so that's spondylolisthesis. Okay? And then that's gonna reduce the area going into those pelvic cavities, right? Make things more cramped. We'll talk when we get into the lower limb about, this kind of force vector. Like it's like the femur isn't vertical, it's actually angled in a little bit, right? And that has implications for like joint wear and tear of the knee joints, like that Q angle. Right? This is vertical, so there's a Q angle. Greater in females than in males, and that's an adaptation to bipedal locomotion. It keeps the center of gravity between our limbs, but over time, it subjects the joints of our lower limbs to a lot more wear and tear than quadriceps experience. So just for humans, generally speaking, end up with wear and tear of their knees, in part because of that. So now, just been talking too much about the pelvic girdle, but we gotta strap some ligaments on to stabilize these bones together. So we're going to drape over the front and over the back of the sacroiliac joint, sacroiliac ligaments. Here's an anterior sacroiliac ligament. Here's a posterior sacroiliac ligament. You're not going to see that in the cadavers. I think I have the cadaver photo in here. We're going to drape a membrane over the obturator foramen. And we'll leave just a little hole in that so that the obturator nerve going to medial thigh muscles can go through. And that membrane will serve as an attachment for some muscles. In fact, our presenters this week are going to show us those muscles, obturator muscles. And then we're going to run two really important ligaments. Okay, let's do it here. This is the spinous process. We're going to run a ligament from the spinous process to the sacrum. You see how I just made a hole? The hole I just made is called the greater sciatic foramen. And then we're going to run a ligament from the ischial tuberosity to the sacrum. And that'll create another hole, the lesser sciatic foramen. Okay, so greater sciatic foramen. I got this on future slides, guys, sorry. And lesser sciatic foramen. If you're wondering why there are inadvertent, spontaneous, unpredictable little lines being directed horizontally, that's a flaw in the matrix in this software, and Bill Gates has never decided to fix it. I think he's got more important things to do, but it's just weird. Okay. And then anytime I focus on it and I try and make it happen, it won't. But like any other time, when I'm not focusing on it, it'll just happen constantly. So, anyways, it's obnoxious. So, we're going to add a sacrospinous ligament and a sacrotuberous ligament. And those will help stabilize these bones, but also add some holes and things like that. So, you can see them here. Okay? okay? Sacrospinous, sacrotuberous ligaments. We'll see both of them on the cadavers, multiple cadavers, and it's really important to see them and think about the holes they make and what's going through those holes, right? Yeah, so this is from, I know I've been pitching Glue Link at University of Minnesota. I like it because it's very simple, it's well laid out, it's not excessive information, it's nice dissections, but if any of you really want to geek out, in my opinion, the world's best anatomy guide to human cadaveric anatomy with photos is a Rohan. I have a copy of it if you want to check it out. I think it's with an E maybe? Rohan et al. Unbelievable. I mean, I've never seen dissections done like you see in that book. So, like here's where your anterior sacroiliac ligament is, and here you can see the sacrospinous and sacrotuberous ligaments, right? Here's that ilioinguinal ligament I was talking about. Here's the pubic symphysis. Pretty cool. This is people sacral promontory. See that little horizontal line there? Bill Gates. Bad. Bad. I don't have any thoughts about Bill Gates. Just I wish he would fix the software. But, as a billionaire, it's the last thing on his mind, isn't it? So this is a view that I think gives you a clear illustration of how adding a sacrospinous and sacrotuberous ligament makes some holes that didn't exist prior to that. So we're going to run the ligament from the ischial spinous process to the sacrum. We'll call it sacrospinous ligament. Then we're going to run a ligament, and here, if you're modeling this with tape, be careful. It's not like a Band-Aid. It starts on the ischiotuberosity that you sit on, and then it fans out, right? It fans out over a lot of area. And then in the process, look what we just made. We made a greater sciatic foramen, and we made a lesser sciatic foramen. So an example of something going through the greater sciatic foramen is piriformis. You've all heard of piriformis syndrome. You'll work with patients with piriformis syndrome. Some of you. What else goes through there? Sciatic nerve. Many of you will work with patients who have sciatica, right? So that's going through that hole. What's going through the lesser sciatic foramen? A nerve that many people think is the most important nerve in the body, the pudendal nerve, right? It's the nerve going to the penis and clitoris and external anal sphincter, really important. So that's what's going through there, among other things, okay? All right. So we're going to look at those ligaments, model them with tape, blah, 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 blah. And this is a ligament that we'll see in multiple lectures and labs. So we're running from ASIS, anterior superior iliac spine, to the pubic tubercle. I mentioned this about 20 minutes ago, and we're going to call it the inguinal ligament, ilioinguinal ligament, probably more often than inguinal ligament, okay? And look how what's below it. There's that space, and that will allow, importantly, among other things, femoral nerve, femoral artery, femoral vein, to get out of the pelvis into the thigh, or from the thigh back into the pelvis through the femoral vein. Really, really important clinically. People will go into the femoral vein to feed a stent up, to a coronary artery, or all kinds of things. You might need to go into the femoral vein for it. And there's muscles going under that ligament and some other nerves. So these are the main three structures I just talked about. But we'll learn more of the detailed anatomy later, okay? So that's the inguinal ligament. Interestingly, in females, this is a more common site in the inguinal region for hernias, to have stuff herniate under this ligament. In males, it's a different location, inguinal hernias, okay? And here's another view. So running from pubic tubercle to ASIS, inguinal ligament, and you can see femoral nerve, femoral artery, femoral vein coming through here. And there's other stuff going through there too, like iliopsoas muscle, pectineus muscle, lateral femoral cutaneous nerve, whatever. But that stuff we'll learn about later. Okay. All right. So why am I going off? Even though we're really going to talk about this in a future lecture in lab, just want us to think about this pelvic girdle and ligaments that we see on it, and spaces that are formed when we add those ligaments. Okay. So I've just been talking about the stuff that travels under the inguinal ligament. One last time: femoral nerve, femoral artery, femoral vein, in addition to some other stuff like iliopsoas, pectineus, blah blah blah. Okay, we're good. I'm cruising, man. I think I'm on slide 30. Oh, we can just relax a bit. We should just talk poetry.
Yeah.
What do you think? Maybe? Okay. Okay. One of our goals is start thinking about how the hip joint and the lower limb compares to the shoulder joint and the upper limb. Okay. There are many similarities, obviously, but some differences. Say a similarity with the shoulder joint is this is a ball and socket synovial joint with a great range of motion. It's similar. A dissimilarity is the pocket that the head of the femur articulates with, the acetabulum, is really deep, and so this is a really secure joint. So technically speaking, slightly less range of motion than the shoulder joint, right? So some similarities, some differences. So it's a ball and socket synovial joint formed by the head of the femur with the acetabulum. You can see it here. All right. Less likely to dislocate than shoulder joint, but it happens. Happened to my mother, classic case, fell in the shower, dislocated her hip joint. It's like, they can happen. So here's femoral head and the acetabulum. Another similarity with the shoulder joint is we're going to actually increase the concavity, right? It's a concave space that the head of the femur fits into. We're going to make it even deeper concavity by adding this cartilaginous rim around, not the whole circumference, but almost the whole circumference. And that's called the labrum. You've heard of labral tears, right, at the shoulder joint, but there's a hip joint labrum too, an acetabular labrum. And so that's kind of just, keeping the head of the femur even more snug in this hip joint, right? So we'll just add a little bit of cartilage. It's not a complete circle. The bottom part's not filled in, but mostly, okay. We're going to reinforce or add stability to this joint by adding on 3 really strong hip joint ligaments that we'll talk about in a second. It's a stable joint, less likely to dislocate than the shoulder joint. Now, we can attach the femoral head to the inside of the acetabulum, okay, with ligament to the head of the femur. So you might be thinking, all right, I got a head of the femur and there's a little ligament, my finger, attaching it to the acetabulum. You might be thinking that that's really what's providing the most resistance to dislocation of the head. No, it's a pretty weak ligament, okay? That's not the major stabilizing player. Pretty insignificant, okay? Likewise, you might think the artery, and there is an artery to the head of the femur, this little artery right here, might be the major blood supply to the head of the femur. Wrong. Okay, that's a little branch coming off obturator artery. Remember, folks, I'll show you a better picture. There's a hole in the coxal bone called the obturator foramen. We're going to cover it with a membrane and leave a little teeny hole for obturator nerve and vessels to go through. So that obturator artery that goes through here to your, see, there we are. Bill Gates. Bad. Okay. This obturator artery, well, in this case, maybe Bill Gates was trying to help us out, gives off a little tube that goes to the head of the femur. Yeah, Bill Gates sometimes is trying to help us out. So it gives off a little artery to the head of the femur, okay? But that, people, is not the major blood supply to the head of the femur. So I'm showing you two little structures that go to the head of the femur, and you intuitively are thinking they're major players. They're not, neither of this. So this ligament is not a major structural feature, and this artery is not a major supply of blood to the head of the femur. We'll think about what supplies blood to it later. If you look at this labrum around the edge of the acetabulum, it's not a complete circle, okay? So here's a cadaveric image showing you the ligament to the head of the femur. And even though you think it's the strong player, it's not, okay? We're gonna rely on three really strong, some of the strongest ligaments in the human body, wrapping around the hip joint to give it most of its strength. And there's all these muscles on the front, on the side, on the back that are enveloping this joint, also providing stability. And in that sense, it's a lot like the shoulder joint. We've got the rotator cuff muscles going over the shoulder joint, also supplying stability there. Let me just, compare in an exaggerated sense. This is the acetabulum, and this is the glenoid fossa. So, head of the femur, head of the humerus. Which one's more likely to dislocate? The shoulder. Okay. Here's a little cartoon representation of a cross section through the hip joint. You can just see how deep this acetabulum is, and we're going to make it even deeper by adding a little rim of cartilage called the acetabular labrum. Think labia, right? Labrum means lip, just like a little lip of cartilage we're adding. Okay. It's beautiful X-rays. You can see the hip joint. You can see the obturator foramen through which obturator nerve, artery, and vein are going to travel. We can all see some of the trochanters of the femur. We're going to have to learn a lot of the processes on the femur. This week, the presenters are going to show us and talk to us about what I call the P-go-go-Q muscles, the 6 short lateral rotators at the hip. And they all attach close to the greater trochanter, okay? So that's an important attachment site of the P-go-go-Q muscles. Anyone here know what attaches to the lesser trochanter? Do you know what the major flexor at the hip is? Iliopsoas. Iliopsoas is coming down there. Okay. And the greater trochanter is important for us this week because most of the P-go-go-Q muscles are attaching in the vicinity of it. Okay. So here's this kind of not that important ligament to the head of the femur. Like you think it would be important, not that important. Here's the greater trochanter of the femur, which is a really important attachment site for P-go-go-Q muscles, which are the short lateral rotators. But like in this view, in this artistic representation, and we're supposed to, as part of this course, we are tasked with also learning a little bit of anatomy and cross sections. Okay, so every lecture and lab. Oh, I should have. Crap. Sorry. I'm remembering now. It's not too late. Presenters. Every presenter, you need to include 1 or 2 cross-sectional images you can pick, and you need to include a couple radiographs you can pick. Okay, and so like this is an example of a cross section. Like let's say you're presenting on the hip joint. Here we go. You know what I mean? Okay. So every presenter, I think I forgot to say this. I'm sorry. In your presentation at the beginning, when you got your PowerPoint up in the cadaver lab, and you're giving us a little intro before we go to the cadavers. I want to see 1 or 2 radiographs, 1 or 2 cross-sectional images, okay? So what's cool about this cross-sectional image is you can just see all this mass of flesh surrounding the hip joint, all these muscles surrounding it, protecting it. Of course, it makes it difficult to access the hip joint for, hip joint replacement surgery, and that's interesting. Like, there's different approaches, and they all have pros and cons, and it's cool to talk to people who do those surgeries, which approach they prefer and why. And any approach, you got to go through muscle. It's tricky. Some more muscle than others. Okay, so this is a posterior view. I just wanted to show you how the sacrotuberous ligaments fan out, okay, towards the sacrum. So, a few comments on sacrotuberous ligament. So, it's coming off the ischiotuberosity. We're sitting on that. We're gonna see in the cadavers how your hamstrings attach to the ischiotuberosity. So if you were dissecting and you were trying to find the sacrotuberous ligament, one way you could do it is follow the hamstrings up. It's pretty easy to dissect out the hamstrings after you remove the skin. Follow them up here to where they attach to the ischiotuberosity, and then see if you can find this ligament heading over here to the sacrum. Okay, all right. So we'll look for that Wednesday in lab. We'll follow the hamstrings up to the ischiotuberosity, and then we'll look for the sacrotuberous ligament, and then we'll look. I'm jumping the gun. We'll look for the pudendal nerve, which comes out of the greater side of the foramen, goes under the sacrotuberous ligament, and ends up traveling in this fat-filled space on either side of your GI tract, particularly the anus. And the reason there's a fat-filled space, let me do it with yellow, okay? Because we're used to thinking of fat as being yellow in color. The reason there's a fat-filled space on either side of the GI tract is when you're passing feces, right, during defecation, you want it to be able to expand easily. So if you have fat there, it's just easy to do it. And the pudendal nerve is traveling in that fat-filled space. We have a ton of examples of dissected out pudendal nerves. It's a really hard dissection because, like, imagine you're going in blind, and basically it's just this room filled with fat, trying to find the pudendal nerve. It's hard to do. But that's the path of pudendal nerve, going under sacrotuberous ligament into the ischioanal fossa, fat-filled space, either side of the lower part of the GI tract. More on that later in this lecture. Here, we're seeing for the first time the ligaments that are really playing the major role in stabilizing the hip joint. There's 3 of them, because there's 3 bones, right, that fuse early in development during puberty that form the coxal bone. There's the ilium, there's a pubis, and there's an ischium. So there's an iliofemoral ligament, a pubofemoral ligament, and an ischiofemoral ligament, right? So there's 3 major ligaments stabilizing the hip joint, each of them coming off a different part of the coxal bone. And so like here's iliofemoral, here's ischiofemoral, kind of twisting around to the front. And in this view, we're not seeing mostly pubofemoral, the 3rd one. These are the major stabilizers. Okay. So here's a side view, and you can see part of iliofemoral and ischiofemoral. You can see how it's wrapping around, spiraling around the front, and a teeny bit of pubofemoral up here. From what I've read, most sources say iliofemoral is the strongest of these. So it's pretty often like Y-shaped. This guy. Resistant hyperextension in particular. We have an iliofemoral and a ischiofemoral and pubofemoral that wrap these up. There's pubofemoral. Here's some. We used to have this. Davis took it back. We did have a pelvis that I think it had been in sac state for a long time. The rest of the body had been returned, but they allowed us to keep just a pelvic girdle with half of a femur, and they had dissected out everything away except for the ligaments of the pelvic girdle. It was really cool, and you could see the 3 hip joint ligaments, and you could move the femur in the hip joint and just see how the ligaments were resisting movement in different directions. But we lost that. I've never seen that done in any lab, any med school. It was a pretty cool dissection. They took it. So iliofemoral head is making that Y shape. And then we're going to cover it with a capsule because all synovial joints have a joint capsule. That also provides a little bit of stability. And there's synovial membrane and synovial fluid associated with this joint since it's a synovial joint, right? Hey, one more look. See how sacrospinous, sacrotuberous make 2 holes. There you go. Greater sciatic, lesser sciatic. Nice visualization. So you might have been wondering, well, if that artery to the head of the femur isn't supplying most of the blood, let me actually draw this. What is it? Let's tie back. So here's ASIS, here's pubic tubercle, here's pubic symphysis. Okay. So if I run a ligament there, I'm going to call it the inguinal ligament. Okay. And then I could run a femoral nerve, artery, and vein under that ligament to get from the pelvis to the thigh. So then we're going to see when we get to the thigh, there's a deep artery of the thigh. And then that will give off typically 2 circumflex arteries. Circumnavigate, circumference. Circumflex is an artery or structure that travels around something. So these circumflex femoral arteries, medial and lateral, circumflex femoral artery, medial circumflex femoral artery. They wrap around femur. Here's the femur. Here's the head. So, and then they're going to send little guys up to the head. That's how we get blood to the head. Okay? That's the main supply, the circumflex femoral. Not this little guy up here, artery to the head of the femur. No, sorry. Not a major part. So clinically, what we worry about is, like, take my mom's example. Though this didn't happen to her, but it's a class. But she fell in the class in the shower. She's not diabetic, but oftentimes people with diabetes, because of peripheral neuropathy, you lose proprioceptive sense in the lower part of your feet. So now you're not sensing stuff as well. Much more prone to falling. And if you're elderly, you have osteoporosis and more prone to fractures. So you're elderly, diabetic, polyneuropathy, and you fall. And you dislocate your hip. But the second thing we worry about if you dislocate your hip is that you fracture right here, proximal femur, separating the head from the shaft. Or to put it another way, you've just separated by that fracture the head of the femur from its blood supply. So now the head of the femur is going to die, and we call that avascular necrosis of the head of the femur. So
really, really important clinical anatomy, okay? Always worry about that. Any hip dislocation, did they fracture the femur? Because then you worry about death of the head, of the femur. So here's the circumflex femoral coming off the deep artery of the thigh. Femoral artery proper would be here. There's the deep artery. Here's the circumflex guys, and then they give branches that go up to the head. Okay? And so if you fracture proximal femur, separate the head from its blood supply, then you end up with avascular necrosis. Okay? There's a few places in the body where you can see this. Another one is one of the carpal bones, the scaphoid bone. If you fall in an outstretched hand, you'll learn about this later, but if you fall in an outstretched hand, oftentimes the scaphoid is the bone that fractures in your wrist. And oftentimes when you fracture it, the part closer to your fingertips, the part closer to your rib, to your wrist, they lose blood supply. So you get avascular necrosis there. Just a few little things here. Sacroiliac joint, iliac spine, ASIS, greater trochanter of the femur. Here's the hip joint. Here's the obturator foramen. Here's the pubic symphysis. If I draw a line from the sacral promontory to the upper part of the pubic symphysis, I just delineated, right, the pelvic inlet. Just a little bit of a tie back. This is what you sit on, your ischiotuberosity. That's also where your hamstrings are attaching. Okay? Okay, we're going to take a break in 2 minutes. I can't believe I got this far. Usually what happens is I spend like an hour just talking about these two slides here, the different. Okay. So there's a rule. More stability, less range of motion in synovial joints. Less stability, more range of motion. That makes sense. So, glenoid fossa is pretty shallow, pretty slight concavity. So the head of the humerus is not really tightly supported. They're really common dislocation. I bet some of you here have had shoulder dislocations, and I bet some of you have worked with people with shoulder dislocations. This is a much deeper articulation site, so it's rarer, but it happens. Often in the elderly, or if not in the elderly because of a fall in an automobile accident. Like you're sitting in your car, and here's the wheel, this is the dashboard, and your car hits something, and so now the dashboard, driven into your knee, and that pushes your lower limb backwards, and you get this posterior dislocation of the hip joint. So sometimes it's like secondary to traumatic accident. And I'll let Raphael and other folks in your program give you more detail on this kind of thing. But what they worry about, you can deal with the hip dislocation, but they worry about fractures and loss of blood supply, things like that, death of tissue, things like that. Okay, let's take a break, maybe 7 minutes. Come back, finish this lecture. If anyone who's presenting Wednesday is now worried, or you want to talk